Welcome. iPhone 727.
Thank you.
Hi, as our first guest.
Hi. How are
Yes,
you?
as our first guest, I'd like to inform you that you won a prize.
What?
Yes. For being an early bird.
Oh, okay.
What you
Thank
can
you.
do for me is you can direct message me your name and your contact number, and we will facilitate you getting your gift. And we
Oh,
thank
okay.
you.
You're welcome.
Yes. Hi, Dr. Morgan.
Good day, everyone. You all right?
Yes.
Good. Everyone tired? Eh?
Yeah.
Long day.
Okay, so welcome. I see we have two more people who have joined. Welcome to our Doc Talk this evening. Before we begin, we'd like to start with a brief trivia session. Okay? A fun trivia session that will make you all eligible to win surprises and prizes. Okay, the rules are pretty simple. The first person that gets the answer right or answers correctly, they get a prize. All right. What I would need for you to do is to direct message me your contact and your phone number so I can get your prizes to you after our segment is complete or throughout the week. All right, so I'm going to start off with the first question. What is the name of our presenter, Dr. Norad Morgan's practice and its location? Not all at once. Hello? Hi. Welcome, Mr. Godfrey. Are you speaking?
No, I'm not. No, I'm just signing on. Sorry. Hi.
Did you hear the question? We're having a brief trivia segment.
Oh no, I didn't hear the question. I just signed on.
Okay, sir. I'll repeat the question. If you get it right, you'll be eligible for a prize. Okay?
Okay.
All right. So the question that I had stated is, what is the name of our presenter, Dr. Norad Morgan's practice and its location?
Ah. I do not know.
Pardon?
I do not know without looking it up.
At least you're honest.
And I do not want to look it up. I can go back and look it up, but I do not know.
Anyone else?
Nurse Monroe, I see you have all of our guests, their minds are churning with that difficult question. Perhaps we need to make it a little bit more easier for them. And we could ask them probably, what is the specialty of Dr. Morgan?
That's another question. What is the specialty of Dr. Morgan?
STD diseases.
Okay, we'll accept that. Very good, Mr. Godfrey. Infectious diseases. Mr. Godfrey, what you can do for me is you can message me your name and your contact.
Okay.
So I can facilitate getting you the prize.
Will do.
Okay.
Okay.
All right, I have another question for you. Who can tell me which month in the year is HIV awareness commemorated? That's an easier one.
Is it this month, June? Oh,
Oh, no, sorry. You want to try again?
July?
October,
No,
October,
no, sir.
August?
We going down the list? No.
To the shoulder of the road before being crushed under the wheels of a big rig.
Anyone else? Pardon? Anyone else? Okay, let me give you an easy one. But I think it's easier. What symbol is used to represent HIV Awareness Month? What do you see people wearing? Or what do you see around when they're advertising HIV awareness? Ms. Rogers, you're winning.
Is it a red ribbon? No.
Yes, it is.
Ah!
Prize number 2. What's your name?
My name is J. Elizabeth Grant.
Okay.
President Grant, welcome, welcome. That's my ACW sister.
Welcome.
Hi, President Rogers.
You.
Okay, guys. Well, that will conclude our trivia session for now. I will hand the mic over to our Vice President, Mrs. Charlene Rogers. Thank you for participating.
You're welcome.
Good evening, everyone, and welcome again to Bahama Health series. Our clinical care department is very excited about hosting these Doc Talk sessions. And so we have members of their department to do the official welcome. But we take a pleasure in sharing freely with the public, so it's not too late to invite your friends to come on and participate. We have a great session set up here, but I would allow our Ms. Lisa Knowles from verification unit to do the official welcome. Good afternoon, good evening rather to everyone.
Afternoon.
Thank you, Ms. Rogers. A pleasant good evening. We at Bahama Health are pleased to welcome you all to today's Doc Talk. We thank you for taking this time to join us, and we trust that you would take with the wealth of knowledge being shared. Please feel free to ask any questions at the end of the segment. Thank you.
Lisa, I think you may have been having a bit of audio difficulty because we weren't able to hear you. So it seems as though Ms. Knowles is still having difficulty. So I would go ahead and get our session started. My name is Nurse Danishka Moss-Bonamy. I am the manager of the clinical care unit here at Bahama Health. And like our VP would have stated, we are very excited to host these doc series that we put on every month with various providers talking about the most relevant topics in our society today. And today we have none other than Dr. Norad Morgan. And I'm so excited, having been a colleague of his as he was practicing and I was in nursing training. So I will let Nurse Charlton officially introduce Dr. Morgan so that we can get this series started today.
Good afternoon, everyone. My name is Marisha Charlton. I am a utilization nurse here at Bahama Health, and it is my pleasure to introduce our speaker for today's informative session, Dr. Norad Morgan. I'm sorry, Mr. Strawn, can you mute your device, please? Dr. Norad Morgan began his early childhood education at the St. Francis and Joseph Primary School. He then graduated from St. Augustine's College Senior High and pursued and obtained a Bachelor of Science degree in biochemistry and a Bachelor of Arts degree in music from Beloit College in Beloit, Wisconsin. He furthered his education by studying medicine at the University of the West Indies Mona campus in Jamaica and specialized in immunology at Trinity College, University of Dublin, Republic of Ireland. Dr. Morgan is presently employed by the Ministry of Health in the Department of Infectious Diseases. He also provides excellent service to the community through his private practice at Emmanuel Medical Center. He is the adoring husband of the beautiful Dr. Michelle McLean Morgan, and they both share two lovely daughters. Ladies and gentlemen, please join me in welcoming Dr. Norad Morgan.
Good evening, everyone. Good evening. Ms. Charlton, could you, or Nurse Moss, you could allow me to share my screen? I can share it now?
Yes.
Okay.
Responding, can you allow me to share?
She's not there.
I don't know who she is.
Are you able to share now?
Not yet. 1 second.
Why you didn't go be a doctor? Is this like just? Make sure it's still on mute. Yeah?
I'm sorry, Galaxy. Dr. Morgan, are you allowed to share now? Dr. Morgan, are you there? I'm sorry, give us a moment, please. We seem to be having some technical difficulties.
How come you can't share a screen?
Okay, just give us a second. Natasha, can you allow Dr. Morgan to share his screen? I'm thinking that's where we're having the challenge on this end.
And greater investment in transitional housing, job placement, and mental health services for the recently.
Okay, Dr. Morgan is extending his apology. His laptop is having technical difficulties, so he's asking us to just allow him a few minutes to resolve that.
Nurse Monroe, you can perhaps do a few more trivias while we wait for Dr. Morgan.
Good afternoon once again, everybody. And I have a few more trivia questions to ask you whilst we wait for everything to be resolved. What are 3 ways?
Sorry about that. Sorry
HIV
about that, guy.
Okay.
Yeah.
Okay.
I really apologize. My laptop it's probably tired. Sorry about that. I apologize. Sorry, I interrupted something.
No, you can.
Okay. I
Can
can
you
share
share
my
your
screen.
screen as yet, Dr. Morgan?
Yes, 1 second.
Okay.
Trying to, give me 1 second. Oh boy. Trying to. Okay, everyone is able to see?
Yes, we can actually see your files that you have on your desktop.
But are you able to see the screen?
Yes, we're able to see your files.
But you're not able to see the presentation?
No.
Oh, so what's going on here?
You just, from our end, it seems as though you just need to select a file to present.
Yeah, I did that. That's the first time I ever did this. Okay.
Yes.
Okay, great. Whew. Sorry about that setback, guys. Okay, everyone can see. So thank you for having me to discuss HIV and other STIs. I'm going to try to be brief. This is what I do, and I like talking about this because sometimes it's very taboo. No one wants to talk about STIs. People want to talk about diabetes. They'll want to talk about hypertension, cancers. But to talk about STIs and HIV sometimes makes, people uncomfortable. But it is very important because young and old people have sex. And so anyone who has sex can get an STI. And so I'm so happy that I'm presenting this in the month of June, although I get most of my speaking engagements in the month of December, especially the first week in December 1st being World AIDS Day. So thank you for having me, because HIV is always with us and STIs is always with us, not only in December. So thank you so much for having me. So STIs are infections that spread from person to person through sex. right? And they're dangerous because they're easily spread. And some STIs, patients have STIs and some don't even know. And so if you don't know you have an STI, you really cannot be treated. And then the other issue is you are able to spread it, right? So sexually, it can be spread through sexual intercourse, oral genital contact, mouth to penis to vagina, injecting drugs, which is not very common in our setting, definitely not in this part of the world. We don't have many IV injecting drug users. And mother to baby in pregnancy. We don't see much of that now, especially with HIV, that our programs, we make sure our mothers are virally suppressed, and we work in tandem with the obstetricians to make sure the mothers are virally suppressed so that they don't transmit the HIV to babies. In addition to that, sexually transmitted infections such as gonorrhea, herpes, chlamydia are treated expeditiously so that those sexually transmitted infections are not passed on, right? Now, when I give this presentation, I do this presentation with a lot of young people, but we know that STIs don't only affect young people, but they make up the bulk of the sexually transmitted infections, right? So a lot of parents are watching this now and they could, use this for their children. Adolescents get STIs all the time, right? So they want autonomy, they feel that they're invincible, so they participate in a lot of risky sexual behavior. Their hormones are going out of whack. They're developing secondary sexual characteristics, breasts. The guys, their penises are enlarging. Females are starting to take on womanly figures. And so all of this contributes to adolescents participating in risky sexual behavior and consequently getting sexually transmitted infections. About 50% of all STI cases occur between the ages of 15 and 24. But don't be fooled by that, because I'm seeing a lot of STIs are occurring in the third, fourth, fifth decades. We're even diagnosing STIs in 70-year-olds. I just had a case 2 or 3 weeks ago where a 74-year-old female was diagnosed with HIV. So we can't take it for granted. And when patients come and do their annual physical with me, or they just come for a checkup, I always encourage them to do an STI screen. You know why? Because yes, now we're all saved and sanctified and filled with the Holy Ghost. But when you was a teenager, when you was in your 20s and 30s, you were participating in some risky sexual behavior and conditions and infections such as syphilis. Sometimes it could remain dormant. Herpes simplex 2 could remain dormant in your system for years and you don't even know unless you do the blood test. And so I do encourage them to do it because a lot of STIs are curable, and most are curable, but some are treatable and manageable, right? And so screening for these can actually clear them out of your system, all right? So these are the risk factors. So your teenagers and even your adults, remember we live in a sexting age, right? Where you could communicate, affairs could happen easily on WhatsApp. You could communicate with someone in second, set up rendezvous. This is real talk I'm talking about. Nurse Moss, I could talk real, right? Okay, I could talk
By
real.
all means, Dr.
Yes,
Morgan.
I could talk real. So we're in an age now where you can hook up easy, right? So me being an STI doctor, there are many, I have to be aware of all of the sex sites and all of the pornography sites and all of the sites, even locally, where people could just hook up. People could hook up. We are in a pandemic, and at the beginning of the pandemic, remember, a lot of people were locked down. A lot of people were engaging in risky sexual behavior. And guess what? I'm now seeing it because I run the STI clinic here at 45 Collins Avenue, in addition to the PrEP clinic, PEP clinic, and HIV clinic. So we're now seeing our patients now coming in because of what we think was going on in the pandemic. where a lot of people not only were having risky sexual behavior, but a lot of people were exchanging sex for money. Those were some hard times. And a lot of people were exchanging sex for money. So going on these sites, I've had a lot of people who say, boy, Doc, things was so thing. I actually was on a site and I got a lot of clients during that time. My patients are very honest with me. And so these are the things. Now, some of these common, I'm going to go through these very quickly. Chlamydia, gonorrhea, these are the common ones. Herpes, warts, hepatitis B and C, HIV, syphilis, trichomoniasis, okay? Chlamydia, caused by a gram-negative bacteria. It's the most common bacterial infection in the USA. It can cause no symptoms. And so a lot of our chlamydia patients are picked up a lot of our females especially are picked up when they go to antenatal clinic, because chlamydia could hide in your system for years and there are no symptoms. Sometimes there are no symptoms in men either, right? Sometimes chlamydia could hide in the, chlamydia could hide in the pharynx, right? And I'll get to that soon. So some of the complications are infections in the womb. The fallopian tubes could become infected with subsequent scarring, infertility, right? And you could have ectopic pregnancy because of the scarring. So I tell my young people all the time, and my young females, sometimes the decisions we make, the sexual decisions we make could have long-term consequences. Because if you got chlamydia when you were 20, and now you're wondering why you can't have a child probably in your mid-20s, early 30s, it could be because your fallopian tubes are scarred and you are now infertile because of an infection that you have. You're not having symptoms, so it could not have been treated. And that is why I ask patients all the time to get a STI panel, even if it's annually, 6 monthly, if you know you're high risk, because people will say, boy, doc, I've been doing some foolishness. If you could do it every 3 monthly. Patients know when they need to be tested. And you will do a simple urine aptamer test and we could pick up chlamydia, right? Mother to child is another problem, but we don't see that as much because you're screened for chlamydia in pregnancy and the mother is treated in your throat. So I tell people all the time, yes, a lot of people think oral sex is safe. It is safer in terms of contracting STIs more than vaginal or anal sex, but it too has its risks. And so a lot of youngsters and say, man, I could just have oral sex, whether it's conolingus, whatever kind of oral sex, and I will be protected. I won't get pregnant, and the risk of contracting those nasty STIs are low. But chlamydia could hide away in the throat. And so you could transmit chlamydia from the penis to the pharynx, and from the pharynx to the penis, from the vagina to the pharynx, right? And less commonly from the pharynx to the vagina. But these are the consequences of having oral sex. I've had cases where someone would come and you think you're treating a regular tonsillitis, strep throat, or with common bacteria that may reside or cause infection in the pharynx and tonsils. But that patient would come back 2 weeks later and say, doctor, antibiotic you give me ain't working. Then now you can delve into the sexual history, and more often than not, this person could have chlamydia or gonorrhea. Chlamydia and gonorrhea travel as a duo, right? And so I'll give them a ceftriaxone shot, and believe it or not, within 2 days, and azithromycin, which is a tablet used to treat chlamydia, a stat dose, and it clears right up, right? So sometimes as a doctor, we are afraid to delve in the person's STI history, even when they come for an annual physical. And so a lot of STIs could pass us by. You may see a 40 or 50-year-old woman come in, she's married, she's in a monogamous relation, her husband is a deacon or pastor. You don't want to get in the woman business. You don't want to cross that line and say, how's your sex life? That woman could have an extramarital affair on the side and be having condomless sex with someone. Or her husband could be, albeit a pastor, albeit a deacon in the church, could be having multiple partners up there and infect her with some of these things. So we shouldn't be afraid as healthcare workers to delve into the sexual history. because you'll be surprised what you may learn. And some people are very open if they're comfortable with you and you've developed that rapport with them, they will tell you. So a part of the annual physical, I think physicians and nurses should delve into that, right? I won't get too much into that. In 1 to 3 weeks, you start developing symptoms. Some people develop symptoms with chlamydia within 4 days, right? Males, they'll have a discharge. Should they have symptoms, have a discharge from the penis, burning, itching, tingling on urination. They'll say, doc, boy, something may feel right down there. Females with chlamydia may have discharge from the vagina, burning on urination, or they may have low abdominal pains, right? And, you know, in a female, a low abdominal pain could be a myriad of things, but we have to always consider sexually transmitted infections, history, then physical exam. Discharge from the penis is obvious. When you do a speculum exam in a female, you may see a thick discharge. You may do a throat examination. You may see exudates in the back of the throat. And sometimes it's very taboo. We have to ask whether it's a male or female if this person participates in anal sex, because you can have chlamydia. You could get chlamydia from anal sex. You could have anal infections from chlamydia. And so sometimes you have to look, you have to ask, are you having any discharge from the back passage from the anus? You could ask a male, do you engage in sex with men? Are you a bottom? Do you bottom sometimes? You could also ask the female, do you have anal sex? A lot of females have anal sex. And so you could get chlamydia in this way. Or on the other side, the exam could be completely normal with chlamydia. Could be completely normal. And you can only know that person has chlamydia if they were to do a urine aptamer test, if we test the urine for chlamydia, or do a swab, whether it's a penile swab or vaginal swab, and send that to the lab to test for chlamydia. Gonorrhea always kind of travels with chlamydia. And then sometimes, remember, with gonorrhea and chlamydia, sometimes the physician may not send off a test. Sometimes we do. But clinically, the case is clear, and sometimes the physician just treats with the IV injection of antibiotics for chlamydia, the stat dose of antibiotics for the, IV injection for the gonorrhea, stat dose for the chlamydia, because it's clinically clear. And if the person now does not resolve within a week or so, then you may send a specimen off to the lab to test. But usually clinicians treat based on experience, treat based on what they've seen before, okay? Most cases of gonorrhea, vaginal or anal sex. You could have, just like chlamydia, throat gonorrhea, right? Pharyngeal gonorrhea. Female to male ratio, 2 to 1. This may be because the symptoms sometimes are clearer in females, or females are more in touch with this health, and if they see something going wrong, they present to the healthcare provider, right? And gonorrhea is increasing in men who have sex with men, as is a lot of STIs, right? And we ought not forget that a lot of sexual activity occurs under the influence of alcohol, marijuana, and cocaine. In the MSM community, there are parties called chemsex community parties, where at these events, there's drugs involved, all kinds of drugs, to get them in the mood, and they have sex, and usually under the influence of these mind-altering drugs, they participate in very risky sexual behavior, condom-less sex, right? So you have to, when you ask the sexual history, you have to combine that with a drug history, sometimes even with a mental health history. Remember, a lot of people who are bipolar, who are that manic phase of the bipolar, they participate in indiscriminate sexual activities, right? They're manic. So you have to also be concerned about the mental health status of the patient. So a sexual history, you got to go into people's private business and ask them. Sometimes when I ask these questions, my patients' eye pop right open. Say, doc, boy, you asking me these things. I never even discussed these things with no one, not even my best friend. But you have to, all right? All right, in 2 to 5 days, the man will start burning. We call that urethritis. You'll start, the tube that's in the penis will start becoming irritated and uncomfortable, 5 to 10 days in females, right? Gonorrhea itself may not show any symptoms at all. Rectal gonorrhea, they may have a discharge from the rectum. And so sometimes you have to do a rectal exam to see. In men who have sex with men, you have to also examine the prostate. This ain't glamorous work, Nurse Moss. This ain't glamorous, but it has to be done. You may have to check the prostate. Remember, chlamydia and gonorrhea can cause a prostatitis, right? And if this person says they bottom, they have sex with men and they bottom, you have to make sure. Prostatitis is usually treated with a particular antibiotic, but if you know this person is participating in sex, anal sex, you may have to treat them for gonorrhea with the shot and chlamydia too. So a history is very important, right? In males, penile discharge, they'll say, "Doc, man, I wake up in the morning and on my underwear, there's this yellowish sticky discharge." Or they will say, "When I wake up in the morning and pee, man, it feels like pins and needles is sticking me," right? And those are the symptoms of in a male. A female may have vaginal discharge, low abdominal pain, right? Rectal, they may have tenesmus, meaning they may want to stool. When they stool, this feeling of not completely evacuating, or they may bleed from the anus. Gonorrhea, I spoke about, you may have, if it's pharyngeal or throat, you may have pain in the back of the throat that may not be treatable with your regular run-of-the-mill antibiotics that you will use to treat a tonsillitis, so you need more, right? Males, you have this thick yellow discharge. Females, the same thing may happen. The exam may be normal, right? And so syphilis, let's talk about syphilis. I'm seeing a lot of syphilis now. When I was an intern at Princess Margaret Hospital, you never saw a lot of syphilis in the early 2000s. But now, a lot of patients are coming up with syphilis, right? Especially those patients who have HIV. So there may be co-infection of HIV and syphilis, right? It's high in men who have sex with men. A lot of the men who have sex with men, sometimes when they come up positive for HIV, they are co-infected with syphilis. But I've seen a lot of heterosexual, even heterosexual women who are coming up with syphilis. Now, remember, we live in a culture where, yes, it could be transmitted heterosexually, but we have a lot of men who have sex with men, and they have sex with women too. And so you see how now, infections can spread, right? Sexually transmitted, mother to child transmission. We've managed to get that under control because this is one of the sexually transmitted infections that is screened for and can be treated expeditiously in a pregnant woman, right? All ages are susceptible. I'm seeing men in their 40s, 50s testing with syphilis. Females, heterosexual, females in their 20s, you'll screen them for all the STIs, and the only one that pops up is syphilis, right? Both sexes are equally susceptible, higher rates in men who have sex with men, right? And it is rare, really, in homosexual women. So lesbians tend not to get some of these STIs. They may get them if they share toys, right? If they share toys in their lesbian sex, they can get a lot of these STIs, right? Primary syphilis. Now, this is interesting because it could show up between 2 to 6 weeks. It could go up to 3 months, and a chancre is formed. Now, the chancre is painless. So sometimes on the vagina, on the penis, you may have a little sore. You don't know it's there. If you're not one who is constantly inspecting your vagina or your penis, you may not know it's there. And so it's there, it's painless, you don't know it's there, and it usually disappears within days, 2 to 3 days. So you don't know it has ever been there. And that is the first stage of it. We call it a chancre, right? And it may be hidden from view. It may be in the folds, as you see here. It may be in the fold right here. This is the glans penis. That's the shaft right here. And it may just go unnoticed. And while that is going unnoticed, that is very infectious. So you're spreading syphilis when that chancre is there, and it disappears. So you don't know anything is going on. Secondary syphilis, you see this picture here? You have this rash in the palms of the hands and the soles of the feet. Now that usually brings our patients in because that's very visible, right? And you notice any disease that has dermatological manifestations, skin manifestations, is going to get patients to their doctor quickly. And so that's seen. And so when that's almost pathognomonic, meaning that is characteristic of secondary syphilis. So once we see that, we know that's secondary syphilis. And remember, syphilis is curable with penicillin, 3 shots, 1 this week, 1 next week, and 1 the week after. Totally curable, right? Neurosyphilis is a complication, and this is where it remains in your system more. Headaches, hearing loss, balance. So you see the complications as it remains in your system longer. There is there's the probability of getting more complications. Late stage syphilis, these gummas, you see the gumma on the chest and in the roof of the mouth, it can occur in the liver, the bones, and other organs, right? Nerve problems, tabes dorsalis, you could get nerve problems. Syphilis could affect your nerves. It could cause paralysis if it remains in your system and it's not treated. Latent syphilis, now that you've passed all of these stages, syphilis could now remain dormant in your system, and you just, it's the great masquerader. It could hide, it could have many faces, it could disappear and reappear, and it's there. But if it's not treated, the complications are even more grave as you go through the stages, right? And at this stage, you could only diagnose it with blood tests. There's simple blood tests we can do to see if you're positive for syphilis. One is called the RPR or the RPR or the VDRL. And that is a more general test, but the more specific test is called the FTA antibody test, which tests specifically for the organism called the Treponema organism. It's a bacterium that actually causes syphilis. The specific serologic test tells you if you have syphilis. Remember, RPR and VDRL could be positive from lupus. You could have false positive from lupus, yours, all kind of other conditions. But when you get that positive, the second step you do is a specific test, blood test that points that you have that organism. And guess what? It's treatable with antibiotics. It's treatable with antibiotics, right? 3 shots of penicillin and you're cured. Unfortunately, sometimes your blood test remains positive, but we do a specific test to see how much of the antibody you've produced, and after treatment, we want that level of antibodies to go down. That tells me that you've been successfully treated for syphilis, right? Markers. But sometimes your basic test remains positive. Some people throughout life, but that patient has to now tell the healthcare provider, yes, I had syphilis 5 years ago and I've been treated. And so that is information that's important. Herpes is very important. You know, all societies most societies have a high prevalence of herpes. We have herpes 1 and we have herpes 2, right? Herpes 1 usually occurs around the mouth. Herpes 2 is considered genital herpes. Now, I always tell people that a lot of STIs, you don't even have to have penetrative sex, which is whether it's a penis and vagina, penis and anus, you don't even have to have oral sex to get it. Sometimes it's just contact with a lesion or a sore from herpes, and you get herpes. You know, I tell my young people all the time when I give this presentation in youth groups, schools, high schools, junior high schools, senior high schools, you could just come in contact by rubbing up certain STIs like herpes, you can get it. You don't even have to have penetrative sex. HPV, human papillomavirus, which I'm going to get to shortly, just by coming in contact with lesions or vaginal fluid or semen, right? And that is why prevention is very important. Condom use to cover up. But remember, the condom only covers up part of the penis. If the part of the penis, that part that is not covered up comes in contact with vaginal fluid, right? or a lesion at the anus, or a lesion in the vagina, that part of the penis that is not covered up with condom is now, gets infected. So sometimes condom cannot protect you against some of these STIs. And that is how serious, and that's why abstinence, which seems like a dark ages, back in the day, obsolete, antiquated term, abstinence, you talk about abstinence in these modern days, people look at you like you're crazy. But abstinence is the only way to get 100% prevention. Because sometimes using a condom in some of these conditions that you get from just contact doesn't work. That's how serious sexual STIs are, right? So you need direct contact. Mother to child can happen. Most infections are on the penis or vagina. And sometimes herpes is a very tricky thing. Herpes could be transmitted without there being observable lesion. You don't have to have a herpes outbreak to get herpes. And that is, and so if you don't see it, you don't know it's there and it's being passed along. Sometimes herpes is present and people think it's a shaving bump, right? And they think it's a shaving bump, and that lesion may go away on its own. If you have an intact immune system that could clear it, you never knew you had it. But you thought it was a shaving bump, you didn't pay attention to it, and you've passed that on to your sexual partner. Or no lesion may be present, and you still pass it on to your sexual partner. Women are more at risk than men, right? Because of the kind of sex. Remember when there's penis in vagina sex, there's trauma, right? So women are sometimes at more risk of getting these STIs, especially HIV, and I'll get into that, because of trauma, right? There is, whether there's minor tearing during sex, there is some kind of trauma, and we'll get into that. Men who have sex with men are at risk also. So primary, you may see these pain now. Herpes, you don't really need to do any laboratory tests or any biopsy. It is almost when a physician or a nurse, a healthcare provider sees a herpetic lesion, a herpes sore, it's very clear that it's herpes. It's almost when you see it, you know it right away, right? You may get a painful ulcer in the vagina. When you urinate and the urine touches the ulcer, it's very painful. You may get fever, lymph nodes in the groin, right? Symptoms tend to be more severe in women than in men, all right? So that is herpes. So is herpes treatable? Herpes is not treatable. Sorry, herpes is not curable. Herpes can be treated. Sometimes your immune system alone could clear it up, but sometimes we give a cream and we give a medication, namely a cyclovir, that can, what we think, speeds up the process of the lesions disappearing. The lesions are very unsightly, so patients will come to you when they have herpes lesion. Not only are they painful, they're ugly. They can become infected with bacteria. Herpes is caused from the herpes simplex virus. It's a viral infection that lives in your body for life. It lives in the nerves of the body for life. Remember, herpes zoster, shingles, it's in that same family where they affect the nerves. And so this could affect the nerves and cause very painful symptoms, right? It's not curable. It's treatable, but it's not curable. So herpes remain with you. If you're immunocompromised, and when we think of immunocompromised, sometimes we only think of HIV. You could be immunocompromised from alcohol, immunocompromised from chemotherapy, if you have cancer, immunocompromised from conditions such as lupus and arthritis. You use immunosuppressive drugs to kind of dampen the immune response in conditions such as lupus that has an exaggerated immune response, or rheumatoid arthritis that has an exaggerated immune response. You're immunocompromised under these circumstances. Old age renders you immunocompromised. Diabetes renders you immunocompromised. And so patients who are immunocompromised could have bad outbreaks or reoccurrence. So herpes is a condition that can reoccur, right? HIV patients can get it if they're not on their antiretroviral therapy, right? And so it's not curable, it's manageable and treatable. Trick. Trichomonas is another sexually transmitted infection caused by Trichomonas vaginalis. Sexually transmitted, and females tend to present more so than males, where you get a foul, yellowish, grayish, bubbly discharge in the vagina, and it is accompanied by severe itching, right? And so females who have trick will notice, because they'll be on the panty liner, on the panties, you'll get stains. It's a foul smelling odor, which doesn't go away even with frequent baths or showers. And so they could have burning and itching in the vagina for real. So anal genital warts. This tends to be more common in men who have sex with men, but it could occur in anyone, right? It's caused by the human papilloma virus. This is a virus we take for light. Human papilloma virus is the most, infection with this is the most common infectious STIs. People don't know that. Human papilloma virus is everywhere. It's easy to catch, especially during those college age. And we'll get into the condition it causes and the vaccines shortly. I know I only have an hour for this. I'm going to try and speed up. But it can cause warts, anal genital warts, which could be benign, but they could become cancerous. It could cause anal cancer, HPV, especially the oncogenic or the carcinogenic, meaning those strains that can cause cancer. HPV is considered an oncogenic virus, meaning that it infects and then causes cancer. Just like Epstein-Barr virus, EBV, also causes. HTLV1 is another sexually transmitted infection that I'm not going to get in here, that can transform cells and make cells become cancerous. See, we take STIs for granted. They have long-term consequences, long-term deadly consequences. HPV, that is very common. You have benign strains, akin to COVID. We had a strain called, we had the Delta, and then we had the Omicron. The Omicron was less infectious, less contagious, and the Delta was deadly. We had a lot of deaths during that period of Delta infection. Same thing, HPV has about 200 strains. Let's say about 15, 20 of them can cause cancer. All the others are benign. HPV serotype or variant 16, 18, 31 have been known to cause what? Vaginal and vulval cancer, has been known to cause cervical cancer, has been known to cause oropharyngeal cancer. So oral sex with someone who has HPV and you're having oral sex, penis in mouth, in about 15, 20 years, if that person inherited a cancer-causing strain of the HPV, 15, 20 years, that person could have cancer in the oropharynx, in the pharynx, the tonsils, under the tongue. HPV causes cancer in the mouth, causes vaginal cancer, vulval cancer, especially in people who are immunocompromised. So HIV patients are more at risk of having the manifestation of the cancer-causing strains of HPV. Now, the good news is you can clear HPV in a year, up to 2 years, if you have a competent immune system. 90% of people do. But if you're immunocompromised, you don't have that ability to clear HPV. So you're going to succumb now to, if you have co-infection with HPV and HIV, you now cannot clear the benign variants or the cancer-causing variants. You can't clear them. So in 15, 20 years, they transform the cells. 15, 20 years, you have cancer of the vagina, cancer of the oropharynx, cervical cancer, anal cancer, penile cancer from HPV. The 16, 18, 31, 45, 35 strains. These are the strains. These are the cancer-causing strains. Could cause penile cancer. I have a patient now who's suffering. He's HIV positive, and he now has penile cancer. And most penile cancers, all penile cancers are caused by HPV. Most, nearly all. Most cervical cancers are caused by HPV 16, 18, or 31 strains. Most, nearly all vaginal cancers are caused by HPV. So you could have benign, you could have a little wart on the hand caused by HPV, that's benign, but you have cancer-causing strains. These warts could transform even if they're benign, meaning non-cancerous, they could transform into cancer, right? Men who have sex with men present with a lot of anal cancers, anal warts. They can present with anal cancer too, especially if they're co-infected with HIV and are not on their meds, all right? So these unsightly warts can be treated successfully. They can be treated with creams. They can be treated, they can be burnt off, frozen and come off, but more than often enough, these unsightly warts can reoccur. They could be on the anus, the vagina, the penis. You could even see them in the cervix as a doctor. If you do a speculum exam when the female goes for a gynae exam or a pap smear, sometimes you could see them inside the cervix. So HPV, which is very common, can cause cancers, right? But we tend to clear them, but if your immune system is not, now some people who don't have HIV, for what reason we don't know, sometimes don't even clear the HPV. And so they don't clear the cancer, your immune system can clear the cancer-causing ones too, after about a year or two. That's how good your immune system is. But for some reason, and it could be for reasons that I'm interested in, a discipline of immunology called immunogenetics. Sometimes the genetics of your immune system renders you incapable of clearing some of these STIs. And so we have studies going on now in country with COVID, and we call it HLA, human leukocyte antigen, how your immune system, the genetics of your immune system, makes you more susceptible to certain infections, make you less able to clear certain infections, right? It's the genetics of your immune system. And sometimes we cannot tell who. Hepatitis C, we know there's no cure. We know there is a cure for hepatitis C, but it's very expensive. Hepatitis C, like hepatitis B, can be spread sexually. It's very expensive to treat, right? There's no vaccine for hepatitis C, but there's a vaccine for hepatitis B and hepatitis A. And I would like to talk about hepatitis A. You know, a lot of people have oral sex with the anus, right? Meaning they would, the tongue goes in the anus. That is a setup for hepatitis A, right? Oral anal transmission. And so people who are at risk of this kind of sex, such as men who have sex with men, should get the hepatitis A vaccine, should get their HPV vaccine that I'm going to get to right now, okay? So that HPV vaccine. Cervical cancer, I'm going to fly through this. Cervical cancer is real, even in 2022, with the pap smear, which is such a brilliant, it looks rather unsophisticated technology. You can do a pap smear, scrape the walls of the cervix, smear that on a slide, spray it and stain it, and send it off to a cytologist, right? Or a histologist, just to look under the microscope to see if there are any abnormal cells. Pap smear could save your life. Women don't go and get the pap smear. If you have had a normal pap smear, you could go every 3 to 5 years. If your gynecologist or the histologist sees abnormal cells, your gynecologist may say, come back every 6 months, right? But I'll get into more details about that, right? But a pap smear could save your life. You should be getting that with your annual. If you're high risk, like an HIV positive person, or if you've had HPV infection in the past, you should be getting more frequent pap smears. Because guess what? There are 3 stages before you even get to stage 1 cervical cancer. And so now the gynecologist could now intercept with treatment. We wouldn't get into that because that'll take too long before you even get to the stage 1. Some people are presenting with stage 4 cervical cancer, stage 3 cervical cancer. How? When you have a pap smear that can actually see these cells becoming abnormal before it even gets to stage 1 cervical cancer. And so the pap smear is an indispensable tool for women. Now, We spoke a bit about HPV infection. If you have an abnormal pap smear, right, your gynecologist may do a biopsy of a suspicious area with a colposcopy. It's called colposcopy with biopsy. And in this regard, they will do a HPV testing. They will send that to the lab. HPV testing is not done routinely, definitely not in men. Only in the context or in the setting of abnormal pap smear would an HPV testing be sent off. They may do a biopsy also if there's a suspicious lesion to make sure this is not cervical cancer or to clarify whether this is pre-cancerous lesion. Remember I said there are 3 stages before you get to stage 1. Stage 1, stage 2, stage 3. Stage 4 is metastatic, meaning the cancer is spread from the cervix, liver, brain, stomach, wherever. Cervical cancer is completely curable at low stages. It's totally preventable at precancerous stages. The pap smear is important. And so they may send off for a HPV testing. Why? Because if you have high grade, if you have cancerous causing strains of HPV, 16, 18, 31, then the gynecologist becomes more suspicious that this could be cervical cancer because HPV causes cervical cancer. Risk factors, sex at a young age, multiple sex partners. So these are the variants I have here, right? It takes about 15 to 20 years to really get cervical cancer from an HPV infection if you did not clear it. HPV is, I don't want to use the word ubiquitous, which means all around, but HPV is so common. Remember, you don't have to penetrate for HPV. Sharing toys, touching vaginal fluid, a man touching the female's vaginal fluid, then touching his penis, HPV infection could occur. A female touching pre-cum and then touching her private parts, HPV can fit. Rubbing up on vaginal fluids, penile fluids, anal fluids, HPV. It's easy to get, right? And that is why we have vaccines. Vaccines, HPV vaccines, this is groundbreaking. In fact, the guy who discovered HPV won the Nobel Prize. I think it would have been in 2008 because HPV is so preventable with these. You could get them at your private provider. You could get them in any one of the peripheral clinics, Anstown, Fleming Street, Elizabeth Estate. And children get it at what age? 9. At age 11. Boys and girls get it. Why? They get it before they start their sexual life. So you should get it before you start having sex. Definitely before you go to college, right? My daughter's going to get hers. The 2 of my daughters are going to get theirs this summer, right? And it must be given before your sexual debut, meaning before you start sex. But you could get HPV vaccines up to 25, 26. In fact, you could get it up to 45 years old, females, right? It's not therapeutic, it doesn't treat, but it could prevent subsequent infection. So sometimes the gynecologist may give you an HPV vaccine, even if they do your HPV screenings and see that you have cancer-causing variants. They may still give it because down the line, it's not going to treat what you have. It's the gynecologist's role to treat what HPV isn't treatable, but to closely follow you up to make sure that these abnormal cells do not transform into cancerous cells, right? But it does, HPV is not curable, but the vaccine prevents it, right? And so you may even get vaccine up to 45 years, right? Age 11 to 12, you could get your catch-up vaccine 13 to 26. Boys and girls are vaccinated. The boys transmit it. They may not have any symptoms whatsoever, right? But remember, I said HPV could cause what? Oropharyngeal cancer, cervical cancer, vulval or vaginal cancer, right? Anal cancer. And so men who have sex with men definitely need to have the HPV vaccine on board to prevent all of these, right? Right? Sometimes we talk about vaginitis. sometimes there can be inflammation or infection in the vagina, and it's not sexual, you know. And so you have to be careful. You could have a yeast infection, right? Trichomonas shouldn't be here, right? But bacterial vaginosis, it's just changes in the vaginal flora in a female, right? But you could have bad odor, a malodorous discharge, but it's not sexually transmitted. Some females get BV or bacterial vaginosis from condom use, right? They could get it from condom use. It's not sexually transmitted, right? Now, let's briefly, in the next 10 minutes, go into HIV, right? Go into HIV. It's freezing up, eh? Okay, so in 2019, there were 133 new cases of HIV. As of 2019, 6,000 plus people were living in the Bahamas with HIV. 70 people presented with AIDS-related deaths. HIV and AIDS are different. For a patient to present with AIDS, that means they would have had HIV for about 7 to 10 years, and this should not be the case. People should be doing regular testing, especially if you think you're high risk, right? There was 0 mother-to-child transmission in 2019, and that's, you know, if you have one case, the whole department goes crazy of a child, you know, being born with HIV. That sends us crazy, right? So our national prevalence is 1.6%, right? HIV, remember, HIV is the infection. AIDS is the syndrome, right? HIV progresses to AIDS within 7 to 10 years without treatment. With all the sophisticated HIV medicines we have, no one's even supposed to be progressing from HIV to AIDS if you're diagnosed. No one's supposed to even be presenting with an HIV diagnosis and having AIDS-related infection. We call them opportunistic infections because they take advantage of a weakened immune system or AIDS-related cancers. You shouldn't, because you're supposed to be having regular screening. It's a treatable and manageable disease. It's not curable, but it's treating. It could be treated, right? And we have so many different medications in 2022, right? Remember, HIV destroys your immune system by killing your helper T cells, right? And so if you're not on medication and years are passing and you're not on medication, all your T cells and some other immune cells are being killed off. You don't even know it's happening. And so now you move from HIV infection to a syndrome where you have no immune system to fight infection, no immune system to fight AIDS-related cancers. Because remember, your immune system is also responsible for keeping cancers at bay and for trying its best to clear cancers, certain cancers of your system, lymphomas and certain cancers that are related to HIV. If you don't have no immune system, you succumb to that, right? 1 out of every 50 person in the Bahamas is HIV positive, 1.6%. Look at this. This is how the virus looks anatomically. It looks very simple. Looks very simple, but it could wreak havoc on the immune system. I won't go into this. The nurses here would understand it, but viruses, just like COVID-19, have coexisted with man for millennia. And so the viruses know our system, right? And so all the virus want to do, they're very intelligent, is survive. So it's binding and it's trying to create more copies of itself. But in doing that, it's infecting other T cells. This is a T cell here. And it's creating more of itself. This is how intelligent viruses are. They're simplistic in their anatomy and in their genome, but they could be very, very devastating in their pathology and their pathophysiology, meaning how they create disease. And so all it wants to do is bind, get into the cell, using its personal machinery, and then when it gets in, it uses our machinery to create more of its cells. All viruses do this. COVID-19 do this. They're very smart. And their modus operandi, their MO, seems to be similar. They may have different ways of doing it, different proteins in doing it, but the end point is it wants to come in the host, which is the patient, and survive and creates more of itself. Same thing going on here. All it wants to do is survive. But in HIV, how it creates disease is that it specifically has this attraction to the immune system. It is one of the few viruses that specifically targets the immune system. And so it binds to your T cells. So it is a virus that affects your immune system. And if you don't have the immune system, you can't fight infection. That's what's going to kill you. If you don't have an immune system, you can't fight certain cancers. Those cancers will kill you, right? And so this is how HIV causes disease. In attaching, creating more of itself, it continually destroys the T cells. So until your immune system is obliterated, if you're not an HIV meds. Now, viruses are smart. You may say, man, your immune system is no match for HIV, but your immune system is trying to clear it. There are mechanisms in our immune system that is trying to clear the HIV, but HIV is smart. It has its own proteins that evades our immune system every step of the way. Sometimes HIV even hides in the cells, away from medication, I'll get to that, and away from your immune system. It hides away from your immune system, meaning that the immune system is not alerted. So the immune system, they're going along, don't even know the HIV is hiding in your cells of your kidneys, hiding even in CD4 cells, hiding in cells in the brain. It's hiding away, and that is why HIV is incurable. And I'll get to that. It is trying its best to survive and go unnoticed in the patient's immune system. And that is why HIV trumps the immune system and wins, because it has built in its mechanism every step of the way. Our immune system puts a mechanism in place. There's a mechanism the virus have to override that and remain unscathed or go unnoticed or so the immune system can clear it, right? HIV, sex. You can't get HIV from sitting on the toilet, from drinking out of the same cup. In fact, the levels in vagina are negligible. You can't get it like that. Can't get it from hugging, can't get it from kissing, cannot get it from sharing towels, cannot get it from shaking hands. You get it from sex. It can be transmitted from mother to child. Drug using, right? Unprotected sex. Sharing needles is not. Blood products, transfusion. That may have been in the early 90s. That's not a problem now. Blood samples are tested, almost obsessively for all kind of bloodborne infection. So that's not possible. And it's not only HIV, it's hepatitis C, syphilis. When you go to the blood bank to donate blood, that blood is screened. Okay? All right. I'll skip over this just to say that HIV in women, we take it for granted that women are becoming a key population or a high-risk group, right? In many parts of the world, in the eastern part of the world, remember, women don't have rights. A lot of women are raped. A lot of men have 10, 12 women in certain countries in the East, right? And that woman can't open her mouth and say, you gotta use a condom. So that man is now having sex with 10 women and bringing infection to the woman. So a lot of women in other countries do not have rights, sexual rights, right? A lot of women are raped, they're abused, and even in our Western society, in places, like Atlanta and stuff, a lot of women are with men who have sex with men. And so they are becoming a high-risk group also. But just anatomically and physiologically, the vagina has a larger surface area. As I said, during sex, women are at risk for tearing, for trauma. And so HIV moves from the semen into those tears because there's blood. If there's bleeding, blood vessels are broken, the HIV can move into the bloodstream, right? And so the same thing with anal sex, and that's why men who have sex with men, or women who have anal sex, or men who bottom, are at high risk because there's tearing, there's trauma. What is the immunology of that? When you have trauma, you get a cut, your immune system kicks in. The immune cells race there innocently, are going to race to the vagina, are going to race to the anus, and the CD4 cells, those same cells that are affected, macrophages, dendritic cells, which are immune cells, are going to the site to what? To try to fix the problem. That's what your immune system under normal circumstances do. But while they are there, remember I said HIV is a virus that affects the immune system, innocently, they're there, trying to repair the trauma from anal sex or vaginal sex. And what happens? The HIV is right there waiting. The HIV infects them, plop, the CD4 T cells, infect the macrophages. And guess what? That infected cell now goes to neighboring lymph nodes. And now that HIV jumping from immune cell to immune cell and causing infection. That is why in the early stages of HIV, you get swollen lymph nodes because there's a lot of activity going on in the lymph nodes because there's infection going on and inflammation going on. So that is why women get it easier than men. I've had couples where the woman is positive, but the man is negative. The woman is positive for HIV, but the man is negative. Sometimes it is more difficult for a man to get HIV for an infected woman, right? Same thing with anal sex. So your immune system is innocently trying to clear the virus, but guess what? HIV is waiting right there to infect these cells, right? Semen can stay in the vagina longer, right? This means you're exposed to the virus longer. Untreated STIs, vaginal yeast infection, bacterial vaginosis, herpes, syphilis, STIs, whether it's in a man or a woman, increases an individual's risk of HIV. I can't say that enough. Untreated STIs put you at risk for HIV. There is a bidirectional relationship between HIV and STIs, especially the STIs that come with ulcers because they bleed easy. And so it's a perfect setup, a perfect portal for HIV to now get into the bloodstream. That's why STIs have to be treated because they are a risk factor for HIV. Not only that, how do you get an STI? From sex. So if you continually present to my STI clinic with herpes, with syphilis, gonorrhea and chlamydia, you know HIV is right around the corner, right? Because the mode of transmission is sex. And these ulcerative lesions are the perfect setup for HIV. We spoke about the abrasions and we spoke about gender-based violence. Even transgenders are at violence, physical violence, rape, and all these kind of things. Women, right? We spoke about all of that, okay? A lot of women wouldn't dare ask their husband to do a HIV test or to do a STI screen. They will become subject to violence. They will become subject to violence. I had a patient when I first started the program. She was diagnosed with HIV. She was living in eczema. She said, "Doc, I got to get on eczema." She came to Nassau to see me. She said, "I even ain't joking. If he find out I have HIV, I dead. He has a gun, I dead." And within 3 months, she successfully moved out of eczema and she left him quietly without incidents, right? In fact, I just saw her the other day. She's doing well. But a lot of women can be subject to gender-based violence, right? Right? History of sexual abuse. So this bidirectional relationship of ulcerative STIs and HIV. Now I told you how the ulcers or how the STIs can cause HIV, but the other direction now, HIV lowers your immune system. We spoke about immunocompromised patients for whatever reason, but mainly HIV. Let's talk about HIV. If you do not have a competent immune system, you cannot clear infections like HPV. You'll continually have recurrent herpes breakout, genital herpes. So if your immune system is not functioning properly, you're now at risk of having HPV. And you could very well be harboring those cancer-causing variants. Okay? Okay, I spoke about this. The longer you take without HIV meds, you're going to progress to AIDS. AIDS mean that your immune system is decimated. You're immunocompromised, right? Your CD4 count are those infection-fighting cells that HIV infects. As time goes on, HIV will kill them out and they can get lower. And the virus is going to go up. So it's this inverse relationship between CD4 count and HIV RNA just means the amount of HIV particles. So when we monitor patients with HIV, we're looking at these two parameters more importantly. We want the CD4 levels to be high if you're on medication, and the amount of virus to be negligible, to be zero, what we call undetectable levels. And that is the goal of anyone who works in HIV. And if your patient is on HIV medicine, the goal is to get you undetectable in the shortest possible time. Because an undetectable patient will not progress to HIV, will not progress to AIDS, can't, because you don't have any virus to infect and to kill CD4 cells and render you immunocompromised. And we want the CD4 to be high and the amount of virus to be low, right? And so that is the goal when you're on medication. If you're not on medication, the CD4s are going to be depleted, you're going to progress to AIDS, and you're going to have a high HIV virus load in your system. All right? So that's the natural history of HIV, right? If you're not on treatment, you're going to succumb. Now, that being said, how do you know you have HIV? You know you have HIV, you don't know, because you usually get an acute infection, fever, little cough, little muscling, sore throat, headache, feeling yucky in the 2 weeks after infection. But guess what? That could happen with COVID. That could happen with coronavirus just causing the flu or causing the common cold. That could happen with influenza. So some people don't pay attention to that. And so in 2 weeks, sometimes in 2 weeks with HIV, it's a masquerade just like syphilis. The symptoms disappear. You may have a little swelling in the neck, but you may just think you have a flu. And guess what? It's tricky. After that, after you get over that, then everything go normal. That time, the virus is wreaking havoc in your system. So it goes unnoticed because the symptoms are so non-specific. All viral infection, hepatitis B, hepatitis C, present with these non-specific symptoms. And HIV does the same. And there it is. It could go unnoticed, right? AIDS, when you get to the point of AIDS, it could cause all these symptoms. AIDS can affect every organ system from head to toe, I tell patients, right? And these are some of the problems with HIV. You could get thrush, these lesions. Now, we don't see a lot of these manifestations of AIDS, like probably in the 90s and early 2000s, because a lot of our patients are virally suppressed. So they will never progress from HIV to AIDS, right? But it can happen if someone is not taking their HIV meds, right? Screening. You could do a simple antibody. You could do a rapid test. The rapid usually looks for the antibodies. Remember, when you get any infection, your immune system produces antibodies. All the antibodies, it's molecules in the immune system to say that you were infected with something. The antibodies remain for life. And HIV testing capitalizes on this, tests for the antibodies that don't go away. So you could be virally suppressed, your virus could be down to 0, but you could still test positive. Why? Because it's the antibody test is testing for the antibodies that remain for life. So although you have 0 virus in your blood because you're taking your medication regularly, you will still continually test positive because the antibodies remain for life. Sometimes we could test for just the antigen, and that's usually a quicker test. Within 2 to 6 weeks, you could know if you're positive, right? The antigen. Antibodies take 3 to 12 weeks to develop. So 2 to 3 months. So you could have sex tonight with an HIV positive person, and I could test you in 2-3 weeks, and you're still negative. You are in the window period because it takes time for your immune system to develop these antibodies that we're looking for. It could take up to 3 months, some people up to 6 months, rarely, usually within 2 to 3 months, right? So people could, people say, but I just was there and I was negative. And now I come and test in 2 months, I'm positive. I don't understand. The person was in the window period. The antibodies were not developed yet, right? So we tell them this. Antigen testing for the P24 antigen is usually a quicker test. So there are various ways to test, but they're available privately, they're available publicly. There's no excuse. Rapid tests are all over the island. People even do house calls with rapid. Certain foundations that have high risks, like men who have sex with men, certain foundation and organization that can cater to men, they do it at parties if you want it done, right? And drugs, there are many drugs we have in country that affect, what are the drugs doing? The drugs are targeting the virus at every point where it's trying to infect, right? We won't get into that right now. Now I want to talk about, and these are the drugs we have in country. I want to talk about PrEP, PEP, and treatment, okay? So and finish, HIV prevention. So we have PrEP, pre-exposure prophylaxis, PEP, post-exposure prophylaxis, and then we have treatment if you're HIV. Let's talk about HIV prevention, right? There are many ways to prevent HIV. You could use your condoms. You could use your female condoms, male condoms. You could use microbicides. You could use gels, you know. What people don't think about, treating HIV is prevention. We call it treatment as prevention. If a patient is on their meds, their HIV meds, and their virus is 0, they cannot transmit HIV. And that is why we work diligently to get people virally suppressed, because they can't pass on the virus. I have couples, one is positive, one is negative. The one who's positive is virally suppressed. They don't use condoms, they're honest, they don't use condoms. The one who's negative is not on PrEP, which I'm gonna get to, and they have sex continually. And the one who's negative, now I don't encourage it, the one who's negative remains negative 5 years now, because the person who's positive is on their meds and they are virally suppressed. And so they can't transmit the virus, right? But when we talk about PEP, we're talking about someone, let's say us healthcare workers, we could get a needle stick, right? We could get HIV from a needle stick, very low risk. But we can take a regime of HIV medicines for a total of 28 days, provided that you present to me within 72 hours to prevent you from getting HIV. A lot of people don't know. It's called PEP, post-exposure prophylaxis. It's very important. And I can't stress how important it is. So that's occupational needle stick. But someone may present to me and say, Morgan, man, on the weekend, I was so drunk. I slept with someone. I'm hearing rumors this person is HIV positive. I didn't use a condom, right? That patient is exposed post-exposure, PEP, post-exposure prophylaxis. If that patient presents to me within 72 hours, I prefer within 24 to 48 hours. I can put them on medication for a month, and that will prevent them from getting HIV, right? Right? And it works. Now let's talk about PrEP. That's PEP. Now, when you come to me, I'm going to screen you for HIV and do your liver profile. I'm going to do your STI screen and all of that too. If you're a female and you may have been raped, you'll get the morning after pill. We may treat you for other STIs that you can get also. But my target at that point is to prevent you from getting HIV. So I put you on PEP. PrEP, the buzz is PrEP. PrEP is for high-risk groups, taking 1 tablet a day. If you're in a high risk, for substantially high-risk patients to prevent them from getting HIV. Who are our high-risk patients? Men who have sex with men. People who have sex, transactional sex worker, exchange sex for money. If one partner is positive and one partner is negative, the negative partner needs to be on PrEP to prevent transmission of HIV. These are high-risk groups. Someone who keep coming to me with STIs. I run an STI clinic. If I see someone continue to come into me, man, every 6 months you come in with a new STI, that patient is at risk for having HIV. So continual STI infections, I will stop and have the conversation about PrEP, pre-exposure prophylaxis, with that client to say, hey man, listen, you heading down the wrong path. The patient may admit, man, doc, I don't like condoms. I have risky sexual behavior. I have condomless sex all the time. I participate. I'm a guy. I like having sex with men, but I also like having sex with women. These are high-risk scenarios. And so this patient needs to be on PrEP. PrEP didn't just drop out of the sky. Someone didn't just wake up in the morning and say, let's create PrEP. PrEP has been studied in many countries, in many different groups, right? And these are the studies here. We wouldn't get involved in that. So it was diligently studied, and it is shown to work. PrEP is what? Taking one tablet every day as long as you're in that scenario, right? Some people are in a serodiscordant relationship, one patient positive, one negative. That patient who's negative needs to be on PrEP. A lot of men who have sex with men, they travel to Atlanta or New York, and they visit gay clubs where there are chemsex parties, as I mentioned. They need to be on PrEP because they participate in risky sexual behavior. They need to be on PrEP. They are at risk for getting HIV, right? Now, I get end with this. Why can't we cure HIV? We cannot cure HIV because HIV hides in cells away from your immune system and away from medication. From the first time a patient was diagnosed, they develop what we call reservoirs, meaning HIV could hide in cells for 2-3 years without. Remember I showed you how HIV infects? It attaches, then it goes into the cell, then it makes copies of itself by bursting out of the cells. And bursting out of the cells, it destroys the cell. And that's how the CD4 T cells get depleted year after year. However, sometimes HIV is smart, just like herpes. And now new studies are showing that COVID-19, SARS-CoV-2, the virus that causes COVID-19, may actually hide in these cells. They hide in these cells, right? In the primary lymphatic cells, in the brain cells, in the kidney cells. They will just go in, and don't try to create any copies of itself. It just hides in there. And then for reasons we don't clearly understand, it could be because of your immunogenetic, 2-3 years, that cell just decides, okay, HIV just say, I'm ready to bud now. And so you get new infections. Even though that person is undetectable, they get a fresh, what we call viremia, meaning the cell just wake up. I mean, the HIV just wake up and say, man, after 2 years, it stretches, it yawns, and say, I'm ready to burst out of the cell and infect other T cells. And so the problem is HIV hides from first time of infection, and it is difficult to clear these cells of this HIV. So the medication can't reach it, and the immune system is not alarmed because it's hiding in the cell. And that is why we cannot cure HIV. Why are vaccines so difficult? HIV, I tell you no lie, is like 5 million different diseases. HIV mutates like crazy. So HIV in the body changes its coat millions of times. Remember, a vaccine, we were lucky with the COVID-19 vaccine because you have one spike protein, which is antigenic, meaning that spike protein alarms the immune system. So now you could put that spike protein in a vaccine and your immune system say, ding, your immune system wakes up to it and start creating antibodies to it to clear it. And so because of all the previous researches that were done on previous coronaviruses like the MERS and the SARS-CoV-1, the spike protein is in all of those. And so it goes straight across the board. And so you could use it now in vaccines. But the HIV virus does what? Changes itself all the time. It's very mutagenic, meaning it mutates. And so you can't have in one vaccine 5 million different variants. And so that is why HIV cannot be cured. 2 reasons. It hides out and we can't find this vaccine. But guess what? They do think that they're going to use this mRNA technology. This is how the Pfizer and the Moderna operates, on the mRNA biotechnology. This is what's in the vaccine. It has the spike protein that is now, you have a thin layer surrounding the spike protein. The spike protein now goes, the genetic material for the spike protein now enters the cell, and now the spike protein produces itself on the human cell, and now your immune system, this is a simplistic cartoon, but this is the essence of it. And now the immune system recognizes the spike protein. So it's a very elegant way of kind of tricking the immune system or sensitizing the immune system to the fact that something foreign is in your body. And now when you're now subsequently infected by coronavirus, those antibodies waiting to now attack. Okay, so now a lot of research is being done in South Africa with this new technology that we now have for the COVID-19 vaccine, more so with the Pfizer and the Moderna. They're trying to implement this. Now, what would be the equivalent of the spike protein? We'll see, but there are various things in the HIV virus that the immune system can respond to, and we'll see how successful that is. We've heard of the Berlin patient who was cured by stem cell transplantation. More recently, it was in 2016 or 17, the London patient, Castillejo Adam, was cured of a bone marrow transplantation, right? And so there is hope. HIV, I feel that the vaccine will come. I feel that they're going to be newer treatment. We now have a 1 monthly shot that you can use for PrEP, and for HIV treatment, cabotegravir, that we can now use for HIV treatment 1 monthly. It's $4,000 a month, but eventually better treatment options are going to be for HIV, right? A cure may come if we could get these reservoirs out of the cell, if we could somehow stimulate the cell to now expel those viruses and let the immune system recognize them, let the antiretrovirals treat them. I do feel that cures will come, functional cures would come. Before we get a cure for HIV, we may get better treatment, right? Vaccines, as I said, are on the horizon. Stem cell, which is extremely expensive, is not a viable option now because of the risks of bone marrow transplantation. Infection is a complication. You have to find a match. It's expensive. So that's not a viable option now, but it seems like that's the only way to cure HIV now. The average man cannot afford it. The average man cannot get it. Very few centers in the world do it. But cures are on the way for HIV. Thank you so much. And I know that was longer than 1 hour, but thank you so much for having me. And are there any questions concerning it? I see some people are still on. I didn't put people to sleep.
No, Dr. Morgan, certainly not. And I will actually agree with you that we all know that sex is something that is definitely taboo in our society. And so having these frank and intentional talks about this conversation is much needed. And I'm happy to hear that you said that you do several presentations to youth, youth groups. So my question to you is, now I know for children attending physicians, going to the doctors in our country, you have to be accompanied by an adult. So let's just say you had this conversation in a school setting, and afterwards a child decided that they were going to, contact you. They wrote down your number and they said, okay, Dr. Morgan, I need to have a chat with you. And they appear and they show up to Victoria Gardens Clinic without an adult. How would that situation be handled?
Now, if you are not 18 or older, unfortunately, I cannot see you. Whether it's for STIs, HIV, diabetes, you buck your toe, you get shook with nail, I can't see you. If you are not 18 or older, and so that restrains me, right? I've had several, however, if you come with a guardian, if you come with your parent, and I've had 17-year-olds diagnosed with HIV, 16-year-old, most recently a 15-year-old was diagnosed with HIV and she is pregnant. So, that was just like, I was like, oh my goodness. So a 15-year-old was recently diagnosed with HIV and pregnant and was actually impregnated by an HIV patient. So that's a whole different story. But yeah, it ties my hand. Unless you come with a guardian, I can't see you. And so that ties my hand. In fact, you can imagine me going to a school mosque and talking about PrEP in the adolescent group and ask conservative society, they'll really, the Christian Council will be all over me. I'll be in the newspaper, I'll on every social media
It may be
platform.
portrayed
Look,
as encouraging our youth to have sex, you know?
Yes,
It's
yeah.
very much taboo in this society.
Yeah, it's very taboo. And remember when PrEP was first started, with men who have sex with men, they were called Truvada whores because people thought they were just gonna indiscriminately just have sex, you know, and it was so taboo. They thought STIs would go up. In fact, stigma and discrimination is still associated with the use of PrEP. They think that these are, you know, whores. People are just unrestrained, will just have unrestrained sexual risk, participate in risky sexual behavior. So there's taboo with PrEP. There's taboo with talking about sex. There's taboo with PrEP because, face it, there are young boys in high school who are having sex with their colleagues and are having sex with older men. I see it every day. And so PrEP is a discussion we need to have at the high school level. PEP is a discussion we need to have at the high school level. And HIV therapy and treatment, screening in this group. You know, I think we'll pick up a lot of HIV positive cases, even in the high schools, because you see it, they're having sex with one another. And a lot of high school students are exchanging sex for money, females and males, heterosexual relationships and homosexual relationships are exchanging sex for money. But these are taboo issues, right? But we need to have that frank conversation.
And I see our questions starting to jump in the chat. Early in the presentation, you would have mentioned and talked about a particular couple that you had where one was negative on PrEP and the other one was positive, and there not being any transmission of the disease. So I think that would have addressed one of our guests in the audience is asking, if a person is constant with the PrEP program, how can they be protected from contracting the HIV without condoms? So the answer to that question is yes.
HIV is not as easy to transmit as people think, you know. It's a very fragile virus. If a drop of blood, if you have your skin and HIV infected blood drop on your skin, that's a barrier. But HIV dies within seconds to minutes of coming in contact with air. It has to get directly into your bloodstream in order to cause infection. So I've had people who dudes come to me and say, they've been with an HIV positive woman for years and they don't get it. And sometimes the woman isn't virally suppressed, sometimes her viral load is high, but it's not as easy. Hepatitis B and hepatitis C are more infectious than HIV. Right? It's not as infectious. It's not as infectious. You have to have multiple sexual encounters. And if the person is virally suppressed, and I don't encourage this, but I have couples, one is positive and virally suppressed, and they haven't told their partner yet. And for some reason, their partner may, I don't know if they encourage them or present for HIV tests. There are creative ways we could get them to do it. And they don't know their partner positive to this day. Their partner is undetectable, but they haven't disclosed to their partner. Now that's dishonesty, and it's actually illegal. I have the laws here, but you know, I cannot divulge someone's HIV status if I'm not giving it. No, I cannot. That's what? That's problem. And in fact, that is not only unethical or illegal, but it can be, you could cause someone to get killed. We live in a real society where guns all around, where people,
They're not as emotionally intelligent as they should be and resorting to violence.
Now, this person been sleeping with this person and don't know their status. So the onus is on them too, to a certain degree. That's why I encourage all people, married people, you are meeting a partner for the first time, get a STI screen. In marriage counseling, some marriage counselors, some pastors and priests, they make sure the two people get STI screening before they even marry.
Yes.
They encourage them to do so. So STI screening is very important.
It certainly is. One of the things you haven't, I may have missed it in the presentation, but we all know that it's still a stigma attached, just like mental illness. There is still a stigma attached to HIV. if I'm, and we know that HIV meds are dispensed at Victoria Gardens Clinic, right? Which is the public clinic where you guys can go, you can get free testing there. But if I'm a private patient, can or have you in some instances was able to source this treatment for your clients in a private setting?
Certainly. HIV meds, public or privately, is free in the Commonwealth of the Bahamas. PEP is free and PrEP is free. So private providers should not charge patients for these meds. Now, there's a fee because there's an office fee, and if the private provider is doing blood work, there's a fee for that. But to charge for the medication is actually not right? So it's free. But they are provided privately. There are very discreet ways in a private setting, even in a public setting, to protect our patients. And so we, nurses, doctors, healthcare providers who do STI, who may do HIV, have very creative and ways to protect the client. We live in a small society. A lot of clients are deathly afraid of anyone finding out that they have HIV, even an STI. So there are ways, even publicly and privately, that we protect the patient. Not only that, there are counseling service, psychological support that we give patients publicly and privately, especially new diagnosis. And there's ongoing adherence counseling and psychological counseling because it's a difficult disease for a lot of people to cope with. It's difficult. And so that support is always there. Sometimes social services support, financial support. We know that patients who have their jobs, who are financially secure, do better in taking their meds, in their self-perception, and all that kind of thing. But there are ways that we protect our clients. There are ways that, as simple as telling your clients, when you get your bottle of meds, you can pour it out in a vitamin bottle. No one has to know your business. No one has to know your business. You tell whoever you want to tell when you're ready to tell, right? We encourage people to be open with their partners, but we can't really force people to be forthcoming with that piece of information. And I try to understand how difficult it must be. A lot of my patients come to me tirelessly to discuss relationships. Say, Doc, I want to be in a relationship, but how do I begin to have the conversation about my HIV status with a new partner? How? Some do it. This is 2022. In fact, I'm seeing it a lot now where a lot of people are coming out and telling their partner, and guess what their partners are doing in 2022? They're coming in for PrEP. PrEP has really revolutionized. I think we are getting better. The stigma with HIV, the stigma with PrEP is there. But I think people are becoming more open with their status, definitely in the States and in Europe. In fact, people are online and in chat groups and in, what you call these groups? They hooking up with people, they say, well, this is my viral load, this is my CD4 count. I am positive, but I'm virally suppressed. Then the other person would say, well, I am on PrEP. Are you on PrEP? People are a bit more, especially in those more liberal societies, like in the European countries, Canada and the United States, people are more open about their HIV status. We haven't really gotten there yet, but we're getting there. Because I have couples come all the time and say, Doc, I'm positive and this is my partner. We have really hit it off and we're in love. I really want to protect him or her. I think he or her needs to start PrEP. I have couples, homosexual couples, heterosexual couples on PrEP. Yeah, so yeah, it's things are changing slowly, but they're changing.
Slowly but surely.
Yeah.
And so I see we have two final questions in the chat. And Doc, I know you would have touched this in the presentation as well, but just for those persons joining us, they would have missed it probably early in the presentation. One of the questions being, if someone has received both of their vaccines for HPV, can they still contract herpes? And secondly, if you have HIV and you're on meds, can you test negative?
Okay, so the first one, or the second one is an interesting question, but the first one, the HPV vaccine doesn't protect you against herpes. It protects you against HPV, especially in the vaccine. are, the vaccine protects you. It has in it, it protects you against those strains that could cause cancer. It may not have those strains that cause benign or non-cancerous disease, but definitely the 16, 18, 31, 45, 35 variants are in the vaccine. Some vaccine have 3 of them, some vaccine has more, right? Just to protect the individual from getting the cancer-causing strains of HPV. And so it doesn't protect against herpes, it protects against subsequent infection with the cancer-causing strains of HPV. If someone is on their meds, and the question is, would they test negative? If someone is on their meds and their virus is 0, they will still test positive for HIV. Remember, I touched on, we test for the antibody test. Those antibodies remain with you for life. Remember, in COVID-19, those antibodies could remain for up to 3 to 6 months and give you some protection, but that wanes. The antibodies for HIV remain, and that's what we usually test. Or we could test for an antigen or a part of the HIV virus. We call that antigen test, right? But a lot of people who are 0 virus in the blood still test positive for HIV.
Thank you, Dr. Morgan. I do not see any other questions in the chat, but Dr. Morgan would have shared his contacts earlier. He's at Emmanuel Well Center, and we'll post his contacts in, or our contacts. You can feel free to contact Bahama Health should you have any questions you wish to ask Dr. Morgan or liaise with the nurses here at Bahama Health one-on-one. We always welcome those. I will now invite Danielle to give our vote of thanks to our audience that has been here with us through this entire presentation. Dr. Morgan has done a comprehensive job on presenting this HIV STI wellness. So Danielle, let's close it out with a thanks.
Yes, I have to say, Dr. Morgan, this presentation was probably one of the most insightful, the most educational, and it was such a great discussion that you would have explained on the importance of HIV, knowing your status, and STDs. So we want to thank you so much for coming in on our Doc Talk and sharing such vital information. I also want to thank our Vice President, Mrs. Rogers, our Medical Director, Dr. Moxie, our Clinical Care Department, our Bahama Health family. Want to thank all of you for helping us to put this discussion and facilitating it to make it so great for Doc Talk. Most importantly, I want to thank the audience for coming in attendance and also asking such great questions for today's segment. Very great questions that we would have gotten, and being in participation. We encourage you, like Nurse Wannabe would have said, to follow our Bahama Health website, look out for our next upcoming Doc Talks, and until then, we hope that you continue to have a safe day, and we wish you a great evening. Thank you so much, and have a wonderful day.
Thank you.
Marvel says the decision will be based on several factors.
As it stands now, the numbers are going down. Hospital cases that require care services is pretty much 0. The majority of cases that are positive in the hospital are incident